Welcome to your review of panic disorder, brought to you by allceus.com. Panic disorder with or without agoraphobia is a common chronic condition that is associated with significant morbidity. Every day, or nearly every day, people experience the fight or flight reaction. Something startles you, something happens, and your heart rate jumps up, your breathing jumps up, you may start sweating, having chills or hot flashes, you get dizzy and lightheaded as your blood pressure drops. You may have a loss of hearing, that is, your ears start to ring or it feels like you're in a tunnel or underwater. You have tunnel vision, you lose your peripheral vision and focus on that threat. And there's an acceleration of instantaneous reflexes. Now, many people experience the fight or flight reaction and don't develop panic disorder. But it is a cluster of symptoms, as you'll see, that is really closely related to a panic attack. Causes or triggers for the fight or flight reaction include anticipatory anxiety, heredity. Some people tend to be a little bit jumpier or more high-strung, as they say. Hypoglycemia, stress, startle or surprise, caffeine, alcohol, decongestants, certain panic-inducing situations, or certain conditions of pregnancy, such as supraventricular tachycardia. Now, each one of these things doesn't necessarily cause a fight or flight reaction, but it tends to cause one or more of the symptoms associated with a fight or flight reaction. We'll see why that's important in the coming slides. Now, for a person with panic disorder, when they start to have a panic attack, their heart speeds up, they start sweating, they start trembling, their breathing often speeds up, or they feel like they have trouble breathing. They get chills or hot flashes. Their tummy starts to feel icky. They may sweat. They may have chest pain. They may have a headache or lightheadedness and dizziness, again, as the blood pressure drops. Tightness in their throat, and the tunnel vision, and a sense of impending death. Now, these are a little bit more severe than the typical fight or flight reaction. But a person with panic disorder often is reacting to something that makes them think that they're going to have a panic attack, when in actuality it may have just been a fight or flight reaction. But as soon as they start to have an increase in heart rate, or have an increase in breathing, or have lightheadedness or dizziness, then they have the anticipatory anxiety of, oh no, here comes a panic attack, and they can work themselves up into a full-blown panic attack very easily. Types of attacks. There's the unexpected attack, the situationally predisposed attack, the situationally bound attack, and nocturnal attacks. When you're diagnosing someone with panic disorder, you want to look at specific phobias. Are there specific things that are triggering panic attacks, or is this a generalized sort of thing? Does the person have PTSD, obsessive compulsive disorder, generalized anxiety disorder? Are they suffering from long-term substance intoxication or substance withdrawal? Is their thyroid in check? Do they have a sensitivity to over-the-counter drugs or food things like sugar and caffeine? Agoraphobia occurs when a person fears leaving or going out into open spaces, which generally means they want to stay in their house where they feel safer. A lot of times, the things that elicit a panic attack in a person with agoraphobia include traveling on buses, subways, or public transportation, being on bridges and tunnels, being far from home, or being far away from somewhere where they think there's medical care. Situational attacks become more common than unexpected attacks in this particular group. Many people with panic disorder also have personality disorders. The most common ones are avoidant personality disorder, obsessive-compulsive disorder, and dependent personality disorder. All of these need to be addressed and treated concurrently with the panic disorder. The risk for somebody to develop panic disorder is higher if they have comorbid depression. They are at higher risk of suicide attempts, impaired social and marital functioning, use or abuse of psychoactive medication, and substance abuse. When you're looking at someone who has panic disorder, you want to figure out how frequent are these panic attacks. Is it several times a day? Once or twice a month? How often is this happening? And what's the constellation of symptoms? Just like every other psychiatric diagnosis out there, there is a set of symptoms, but most people only have a few of those symptoms. So which symptoms does this particular person present with, and what can we do to make their life improve? You also need to look and see whether a person has a sensitivity to the time, season changes, or allergens. Again, some of these things will make the person feel like they're getting ready to have a panic attack because they start getting lightheaded when their sinuses get messed up. The time changes may make them feel a little bit off-kilter, kind of like they have jet lag. So be aware of things that may make their panic disorder worse. The goals of treatment are obvious. Reduce the frequency and severity of the panic episodes. Reduce the anticipatory anxiety. That's the low-level anxiety that exists pretty much constantly with these people that they're going to have an attack. They're just waiting for the shoe to drop. They're waiting for the next attack to happen. Reduce morbidity and improve patient functioning. Outpatient and panic-focused cognitive behavioral therapy are very effective treatments for panic disorder. Pharmacotherapy can be used in patients who are willing to take medication if they feel that it's warranted. The first goal, as always, is to establish and maintain a therapeutic alliance. Evaluate and monitor particular symptoms over time. So get a baseline of what's going on with this person when they first present to you. How often the attacks are occurring, how severe they are, what the symptoms are. Evaluate the types and severity of functional impairment. These can often be used as your treatment plan goals in order to help the person increase their quality of life. Work with other health professionals in order to provide continuity of treatment. Educate family members and enlist their help when appropriate. Try to enhance treatment compliance, and work with the patient to address early signs of relapse. Whether to use psychotherapy or pharmacotherapy or both depends in large part upon the patient. What's going to be effective with this patient, what this patient wants and will be compliant with, and the risks and benefits of each. Psychoeducation is the first step for just about all diagnoses. Educate the patient about what's going on, what the symptoms are, how this happens, how common it is. Help them develop a method for continuous panic monitoring so they can start identifying when they're getting ready to spike in their panic. Help them develop positive self-statements, development of anxiety management skills, including breathing retraining, and help them with cognitive restructuring. A lot of people with panic disorder have catastrophic interpretations of bodily sensations. The minute their heart starts to race, they think they're going to have a heart attack and die. The minute they start to get lightheaded, they may think that they have a tumor. It's important to help them get rid of those catastrophic interpretations. Some people are okay with in vivo exposure to fear cues. That means, for example, have the person close their eyes and imagine they are in whatever situation that provokes panic, and have them keep doing that until they can keep themselves from getting freaked out. Usually it's monitored on a Likert scale from 1 to 10. Starting with 10 into a complete panic attack, you want them to be able to imagine that situation and not have any fear response at all. A lot of people don't respond well to in vivo exposure. And most people won't respond well to in vivo exposure until their symptoms are generally under control. They need to have the emotional strength and the emotional energy to deal with trying to control fear before it's just spontaneously introduced. First-line medications, SSRIs. They're your first-line medication for just about everything. And we will mention again, as I do in just about every presentation that we talk about SSRIs, that if the patient has bipolar disorder, SSRIs can trigger a manic episode. So it's important to screen out bipolar when you're talking with the patient about potential treatment options. Tricyclic antidepressants, that's your second line. Those have a lot more side effects, but for patients who can't take SSRIs, that might be an option. Benzodiazepines are available, but they are contraindicated for people with a history of addiction themselves and or a family history of addiction in long-term dosing. It's useful if the patient's going to start taking SSRIs or Boost Bar, which take a while to take effect, to have them on a short course of benzos as needed. And the benzos that tend to have a short time between the time the patient takes it and the time it takes effect, they have a shorter half-life, tend to be the ones that are most addictive. So if you can put them on the one that takes the longest to take effect, but it still takes effect within 20 minutes or 30 minutes or an hour and goes down more slowly as opposed to something like Xanax that has a very rapid effective action. MAOIs are probably your last line of defense, at least right now. And they still have a lot of dietary restrictions, and it's really hard to monitor the MAOIs in patients if they're taking other drugs, if they have other medical conditions, or if they don't regularly present for their appointments because they have agoraphobia or obsessive-compulsive disorder. Second-line medications include some of the anticonvulsants, beta blockers, calcium channel blockers, or Boost Bar. The first 12 weeks of treatment is considered the acute phase, but you want to reevaluate your patient if there is no improvement within 6 to 8 weeks. Even with the antidepressants, by 6 weeks there should be some improvement. Now, they're not going to be walking around hippy-skippy like everything's beautiful, probably. But you want to move them on a scale of 1 to 10 from a 1 to at least a 4 within 6 weeks. Your goals during the acute phase are just to reduce the frequency and intensity of the panic attacks and help them improve their day-to-day functioning. This is sort of a stabilization phase. Let's get them to the point where they can rest enough to get the emotional energy to deal with the disorder. Medication response often doesn't occur for at least 4 weeks, and some patients won't realize a full response for 8 to 12 weeks. So if a patient starts on an SSRI and 2 weeks later comes in and says, well, this isn't working, doc, I want to try something else, make sure that they understand that especially the SSRIs are not going to take effect right away. So there has to be some sort of stopgap in between, or they have to be willing to wait. It's also vitally important to communicate with your patients that many of the SSRIs have some side effects when you first start taking them, and if you miss your dose, you take it late, or if you're tapering off of it, where the person will feel lightheaded and dizzy and possibly feel like they're hyperventilating. So some of the symptoms that trigger the panic disorder may be exacerbated initially by some of the antidepressant medications. Let them know to expect this. Otherwise, you're going to have very poor treatment compliance, and if they don't take their medication roughly at the same time every day for 6 weeks, they're not going to feel the full effect, and they may not feel an effect at all. If they're only taking it, they take it once, and then they wait a couple of days, and they try it again. They need to be diligent. Make sure that they understand this, and make sure that they understand that when they're taking an SSRI, most physicians, if not all, will make them completely taper off of one, be antidepressant free for 2 weeks, and then start the next one if they're going to change antidepressants. Some physicians that I've worked with have done a much faster turnaround, but I've never worked with one who will prescribe one medication before the other one is out of the person's system, basically, when they can't be taking Zoloft and Prozac at the same time. With SSRIs, you want to reduce the intensity and frequency of panic attacks, reduce the anticipatory anxiety, and treat associated depression. As we talked about on the last slide, SSRI withdrawal syndrome, and you'll also see these side effects a lot during the first 3 days of taking the medication, include dizziness, lack of coordination, headache, irritability, and the onset is usually within 24 hours, and it peaks at day 5 during withdrawal. Tricyclics can be used for anxiety. Typically, you'll use some of these. Tofranil is the one that we used to see most common in the clinic that I worked at, but it's also up to your physician and what they're comfortable prescribing. Tricyclics have some nasty side effects. The anticholinergic side effects, such as dry mouth, constipation, difficulty urinating, increased heart rate, there you go, that's another symptom there that sets off the panic attacks. So tricyclics also have some of the same side effects that can lead a person to have their anticipatory anxiety worsen, and blurry vision. Sleep disturbance, hypotension, and dizziness. Again, this is another side effect that can actually trigger a panic attack. Cognitive disturbance, weight gain, and sexual dysfunction. Those are symptoms that typically trigger treatment noncompliance more than a panic attack. In order to form a treatment plan, you want something that's observable and measurable and realistic. For brief interventions, in order to help the person see rapid initial improvement, try the miracle question and trigger journaling. With the miracle question, you say, if you didn't have panic disorder anymore, how would life be different? Have them write that down for you, and that is their step B. They're at A right now, and you need to get them from A to B, but you're not going to do it in one ginormous step. You're going to have to take baby steps in between. So break it down into small goals that they can rapidly achieve, maybe in days or at most in a week or so, because they need to feel a sense of accomplishment. And trigger journaling. Have them keep a little notebook, a little list, a little something of things that trigger their panic attacks. Is it caffeine? Is it a certain noise? Is it a time of day? Are there times of day or times of the month that are worse? Have them keep a list of all of these things, and then you can go over them in treatment to figure out ways to eliminate or at least minimize the impact of those triggers. Physical interventions include breathing and positive self-talk, reducing caffeine, getting adequate sleep, and exercise. When someone is having a panic attack, their body is in that fight or flight mode. Their adrenaline's pumping. If they can divert that adrenaline into something that should be making their heart rate go up, like going on a walk, a lot of times they can diffuse some of the associated stuff. Preventative exercise also helps keep their stress down. So hopefully they will be less inclined to get stressed out and start to have a panic attack. Adequate sleep is vitally important. When we're not rested, we tend to be more susceptible to things that would not normally set us off. A lot of people will fight you on reducing caffeine. But caffeine is one of your biggest triggers for people, and they don't realize that caffeine has a really, really long half-life. So if they drink coffee at 2 in the afternoon, the caffeine's still going to be in their system, not to the same extent, but at 2 in the morning. So that's going to negatively impact their sleep. And if they're drinking caffeine throughout the day, they're just adding on to their base blood levels of caffeine. They're really hyping themselves up, and they don't necessarily realize it. Environmentally, help the person reduce stress and increase their sense of safety. If they're not feeling hypervigilant all the time, if they're not worried every time they hear a bump, they're going to be able to relax more, which will help them reduce the frequency, intensity of their panic attacks. In summary, panic disorder is relatively common, and it's treatable with psychotherapy and/or medications. In order to accurately assess, diagnose, and treat panic disorder, there needs to be a 5-axis assessment. You need to rule out any medical conditions that may be masquerading as panic disorder or exacerbating the panic disorder. Look at a history of substance abuse. Look at a history of other psychiatric conditions, and anything else that may be increasing this person's stress, psychosocially or otherwise. Once you have all that determined, you can figure out how to best create a treatment plan that helps the person reduce stress, identify their triggers, control their breathing, reduce their negative cognitive distortions, and live a much happier, more productive life.